My name is Dr Laila Abdullah. I'm a GP, I'm a lecturer in medical education and one of the teacher faculty development leads at King's College London in the QMEC department, King's Undergraduate Medical Education in the Community. I also write questions for the medical licensing assessment, and this interactive video will support you in writing single best answer questions. So by the end of interacting with this video, you should be able to assimilate the house style when writing SBAs, recognise some of the common pitfalls that are encountered in question writing, and consider how to authentically write questions that are inclusive and represent the diversity that we see within our patients and also our students. You'll see on some of the slides that there is a pause button, and at this point it's worth just pausing the video, and if you're watching this video with somebody else discussing some of the scenarios or activities, and if you're by yourself, just having a think and making a few notes. So just a short activity for you here. There are some acronyms which we commonly mention in assessment, including SBA, which I've already given away, but there are a few others here. So just have a quick look at those and see if you know what they are. So we've got SBA, which is the single best answer question. We've got the MLA, which is the medical licensing assessment, and that consists of the AKT, the Applied Knowledge Test, and the CPSA, the Clinical and Professional Skills Assessment. So all medical students as of January 2025 graduating from UK universities must pass this assessment, the MLA, as part of their degree before joining the medical register. So what's the layout of an SBA? So you've got the clinical vignette, which is a clinical scenario that sets the scene and gives the necessary clinical information. You've then got the lead-in, which is a question, and then you've got 5 options. So what do you think makes a good SBA? What makes a question a good question? What makes a question a bad question? So a few top tips here. So one is to really consider your audience. So for the MLA, the medical licensing assessment, the level of the learner is a final year student who's about to graduate and become an FY1 doctor. And the questions that you're writing, you want to ensure that whoever's answering the question is safe to become an FY1 doctor. Sometimes it's quite nice to base questions on patients and be inspired by real cases that you've encountered. And this can really help with diversity, particularly if you're using images of patients that you've encountered in clinical practice. But try to avoid overcomplicated scenarios. Sometimes you might start writing a question based on a patient, but realize very quickly that it becomes a bit too complicated for a single best answer question. Try to ask questions that test application of knowledge. So we have moved away from testing factual, esoteric knowledge recall through to a focus on diagnoses, investigations, management, and skills that we're testing are data interpretation, clinical decision making, clinical reasoning, and problem solving. It's always great to road test your questions on colleagues. So any questions that you write, share it with colleagues and see what they think. So thinking about the vignette, first of all, we want this to be short, so between 30 to 100 words. It should be written in the present tense. Numbers should up to 9 should be written in words and above 10 in digits. And the exception is units of time, so a person's age or the number of weeks that they've had shortness of breath. If it's 3 weeks, for example. Try and use short sentences, simple words and phrases, and check that abbreviations are acceptable as well as acronyms. And an easy way to do this is just to keep the style guide open, and there's another document for abbreviations and acronyms, and you can just search for these within the document. Avoid extra words such as presents with, history of, or on examination. So whenever I'm reviewing questions, it's the first thing that I will do is strike off these phrases. And instead of that, say a 52-year-old man has shortness of breath for 3 weeks, or has had. Try to avoid buzzwords, so things like strawberry tongue or cogwheel rigidity, where you can automatically associate those with a diagnosis without reading the rest of the question. And avoid bad medicine. So this is where something has been done in practice which shouldn't have been done, and may lead to a complication or an error for the patient. And we'll go through examples of this shortly. So within the vignette, within the house style, we should include age and gender, the symptoms and duration that the patient has had the symptoms for. The setting can be included if it's relevant for decision making, otherwise it doesn't need to be included. Any relevant past medical history, family history or social history, and then the physical findings, so observations first, followed by examination findings. Anything that's not included can be presumed normal, but there are times where it's important to include normal relevant findings as well. And then investigations and results. So try to exclude any irrelevant information. So for observations, it's always useful, again, to just have your style guide to hand on your desktop when you're writing questions, and simply copy over the observations that you want to include, and then you can exchange them for the patient in your scenario. So the lead-in, the question. So here, the question that we should be using is which or what is the most likely diagnosis? A decision hasn't quite been made whether which or what is most appropriate to use, so use whatever sounds most appropriate grammatically in your lead-in. Avoid which of the following, because that suggests it's a true-false type question, and avoid negative lead-in, so which is the least likely diagnosis, for example. So with the 5 options, there should be 5 plausible options. So try not to have any redundant distractors, so options which can be immediately striked when reading the question, because that makes it a best of 4 rather than a best of 5. Make sure that the options are in alphabetical order. This just helps those the questions to makes it easier for us. Make sure that the question itself passes the cover test. So this is where the options are covered up, and whoever's reading the question can formulate the clinical reasoning process in their minds and come to a diagnosis without looking at the options. And this is something that I often tell my students about, because it can help to answer questions as well. Sounds silly, but ensure that the right answer and the best answer is among the options, and try and make the options homogeneous, so either all management, treatment options, or investigations. But as we know, in primary care, there is often combinations of things that might be done, or different management options. So a way around this is to ask what's the most appropriate next step in management. And then a mixture can be acceptable. Try and make the answers of similar length, because historically students will pick the longest answer. So wherever possible, they should be similar. So avoid redundant distractors, Make sure that there is no grammatical cueing, so ensure that all the options grammatically link into the lead-in or follow on from the lead-in. Avoid all of the above or none of the above. Those shouldn't feature in any of the SBAs. And avoid true-false type questions. Try and include management options. Don't include management options where there could be a regional variation. This is where it's really helpful to speak to others in different specialties and road test your questions on colleagues, because there may be regional variation in guidance, for example, and wherever there's a grey area, wherever a clinician would have to look something up, it's best to avoid any questions like that or any options that are like that. Okay, so we're going to go through a few questions now, and this is where you will be using your pause button, and try and think about the common pitfall in this question. So what's not good about this question, and what should be changed about it. So we'll start with the first one here. So you can press the pause button now, and I will read through it for those of you that it would be helpful for. So a 62-year-old man attends the GP surgery and has a consultation with you. He has a history of 6 weeks of a change in bowel habit to diarrhea, blood in his stool, abdominal discomfort and tiredness. His wife has commented that his trousers are much looser, and he thinks he's lost approximately 4 kilos in weight over the last 2 months. In his past medical history, he suffers from hypertension, diabetes, lumbar disc prolapse. He is an ex-smoker of 30 cigarettes a day for 20 years. On examination, his abdomen is soft and there is a tender mass in the left iliac fossa. His rectal examination is normal, which is the most important investigation. Abdominal CT, abdominal ultrasound, abdominal X-ray, colonoscopy and biopsy, fecal immunochemical test. So hopefully you will have gathered that there's lots of extra information that's unnecessary in there, and extra phrases and words. The lead-in is ambiguous, so what's important to some might be not as important to others, and there's also 2 plausible options. So have a read of this. This is how I've reworked this question, so that the answer is colonoscopy and biopsy, and have a think. You may spot things that I haven't, and you may spot some faults as well. It's very difficult to write a perfect question, but it's really good to have that critical eye. Okay, so in this question, a 57-year-old man has chronic mechanical lower back pain and was commenced on naproxen and diazepam 2 months ago for a flare. He has diabetes and hypertension. He takes paracetamol, tramadol, metformin, and amlodipine. So his EGFR is 41 and was 57 6 months ago. So what medication has most likely caused a change in his blood test result? Naproxen, tramadol, metformin, amlodipine, diazepam. So the pitfall here is what we'd call bad medicine. So this patient has renal impairment and is started on naproxen, which has worsened his kidney dysfunction. There is a sense of blame of that the doctor shouldn't have started on naproxen, and it would not be best practice. So we would avoid any questions where this sort of scenario takes place. The answers are also not in alphabetical order. In this question, a 67-year-old man has recurrent episodes of dizziness lasting 10 seconds, which occurs mainly when getting up from a chair for the past month. He has hypertension, atrial fibrillation, hypercholesterolemia. His lying BP is 134/83 and standing BP is 112/57, pulse 78. So which drug is most appropriate to stop? Rivaroxaban, atorvastatin, bisoprolol, amlodipine, or ramipril? So hopefully from this question, you'll notice that the answers are not in alphabetical order. You'll get a sense of the importance of that from these questions, and also that it doesn't pass the cover test. So you can't arrive at the answer without looking at the options. So in this question, a 32-year-old woman has dysuria, frequency and urgency for 2 days. She's not had any loin pain, vomiting or hematuria. She's 8 weeks pregnant. Her temperature is 37.1, pulse is 84, blood pressure 122/82. There is slight suprapubic tenderness. Urine dipstick is positive for leukocytes and nitrates, and the urine is sent for a culture. So what is the most appropriate treatment regime? So you'll see here that there is convergence. So your eye is immediately drawn to nitrofurantoin, as there are 2 options, one for 3 days and one for 7 days. So the reader is going to be choosing between B and C. The answers are also non-homogeneous, and D really does stick out and there's a bit of a redundant distractor with the patient being so stable. They are very unlikely to need any hospital intervention at this point. So in this question, a 76-year-old man has had recurrent falls and difficulty with his balance. His husband has noticed that he no longer smiles as much and he's concerned. He drinks 20 units of alcohol per week. He has a pill-rolling tremor in his right hand. He takes a long time to stand up and has a shuffling gait. His neurological examination is otherwise normal. What is the most likely diagnosis? Parkinson's disease, frailty, depression, alcoholic cerebellar degeneration, Lewy body dementia. So in this question, pill-rolling tremor, cogwheel rigidity, those are buzzwords for Parkinson's disease and should be avoided. So if you wanted to include those examination findings, you might want to describe the appearance rather than using the buzz phrases. A 36-year-old woman attends the GP surgery to discuss contraception. She has migraines and menorrhagia. She has 2 children and feels she has completed her family. She smokes 20 cigarettes per day and her BMI is 30. Which contraceptive option is least likely to be appropriate? The IUS, the progesterone-only pill, the combined oral contraceptive, the IUD, or the contraceptive implant? This question has a negative lead-in asking about what's least likely. There are 2 correct possible answers, and it's a true-false type question. And yet again, it needs alphabeticalizing. So in this section, we're going to think about what does your patient look like? So this is one of the questions that we had earlier from the first section about a patient with dizziness. So I want you to have a read of it and think about what this patient looks like. Close your eyes and think about what protective characteristics or personal characteristics do they have. And this might be influenced by a number of things. It might be influenced by your patient demographic in the area that you work in. It might be influenced by your own background, or a patient that you've seen recently that it might remind you of. However, without any information about personal characteristics within this, other than the patient's age and gender, it could be that the default is that this is a white, cisgender, heteronormative, non-disabled, and a-religious patient. And there are a few images here that may have been conjured up in your mind. The patient may have looked completely different in your mind, but we need to think about without including that information, what is the default? And patients are diverse, and there's also intersectionality, and our students are diverse as well. Just a reminder of some of the protected characteristics under the Equality Act. So you've got age, disability, gender reassignment, marriage or civil partnership, pregnancy and maternity leave, race, religion, sex, and sexual orientation. Now, as per the House styling of SBA questions, we only include information on age and gender. So lots of other aspects are not automatically included. Sometimes we include race. So, for example, if a skin rash or skin appearance is described, but there's no image, we would need to say what race the patient is. So, are they black, white, brown, so that the rash can be, or skin appearance can be described. Some of the other protected characteristics may come up in different ways. So in social history, for example, however, it's usually only included if directly relevant to the clinical reasoning process within the question. But I want you to have a think about diversity in SBA questions. Why is it important to include diversity in SBA questions in an authentic way? And if you're with someone, have a chat with the person next to you. If you're alone, just note down some of the arguments for this, and also the potential risks of including this extra information. So I'm compiling my own list of arguments for and the potential risks of diversifying SBAs. And you may well have thought of some other things. But firstly, and it might seem very obvious as we've just discussed, that patients are really diverse, and we know that health inequalities exist. And cultural competency, health inequalities, decolonizing the curriculum, these are all gaining a lot of traction within medical undergraduate curricula and are all really important. And we need assessments to align to the curricula. And therefore, assessments should also be representative of diverse patients. We also know that students are diverse and that award gaps exist, and this is in both undergraduate and postgraduate assessments, and not only in examiner marked assessments, but also in machine marked assessments as well. So there's a possibility, and there is no evidence to suggest this at the moment, but there's certainly a hypothesis that the two may well be linked. It's also a GMC requirement that our doctors, newly qualified doctors, must be able to work collaboratively with patients, their relatives, carers, to make clinical judgments and decisions based on whole person care. So a holistic assessment of their needs, priorities, and concerns, and appreciating the importance of links between the pathophysiological, psychological, spiritual, religious, and individual cultural factors. There are also some potential risks. So one of the reasons why the clinical vignettes are, we don't include any unnecessary information, is to not disadvantage students who are neurodivergent through cognitive load. Students have 72 seconds to answer each question, so it really should be kept to the bare minimum. Historically, medical education has been full of stereotypes, and this is seen in assessment as well. So we don't want to go back there, and there's certainly the risk of that by thinking about including this extra information. And it should be used as a tool for whoever's writing questions to actually challenge their own unconscious bias as well. And think about, does this come across as a stereotype, or is this being included in an authentic way? SBAs are challenging to construct, and this just adds another layer of complexity. And as I mentioned, there is a risk of diagnostic overshadowing. So considering that where a patient has a condition and that information is included and their presentation is attributed to that condition when it could be something else. And the cognitive biases are really something to be aware of. So for example, if we're considering a scenario where a patient is physically disabled and, for example, if they're wheelchair bound, as if they are an amputee, for example, and have abdominal pain, and the unconscious bias could be that they're not sexually active and therefore a pregnancy test is not necessary. So really challenging the reader's bias and thinking about diagnostic errors and how you might incorporate that into questions as well. So how can we include diversity in SBAs in an authentic way? So this is that same example of the patient. And there's just been a very slight change to the words, to the context of how these symptoms of dizziness are occurring. So when standing from kneeling during prayer several times a week for the past month. And this might conjure up a slightly different image of the patient in mind. And it's a way of allowing the reader to be able to imagine a slightly different image and moving away from that potential default of what the patient might look like. Our language should also be inclusive, so thinking about terms such as man or woman with disability or visual impairment, with epilepsy or diabetes rather than epileptic or diabetic person. Using when sexual orientation is appropriate to include in the STEM, the terms are heterosexual, homosexual, bisexual, and thinking about stereotypes as well. So not always making the person being injured playing football a man, or thinking about job roles as well. This is a QR code to some example questions that myself and a colleague, Dr. Adam Shepherd, have written. And in these questions, we've tried to represent diverse patient groups. And what we've tried to do is to incorporate protected characteristics and diversity within patients, particularly in marginalized patient groups. And we've tried to do this in an authentic way. In some of the questions, it's important for the clinical reasoning process, and in others, it doesn't have an impact on the clinical reasoning process. But we've tried to avoid any stereotypes and also tokenistic representation of diverse groups. So please have a look through these questions and have a think about how you might incorporate diversity into your SBA questions. We'd love to hear what you think. And if you've got any questions or thoughts about it or any feedback on this video generally, I'd be really happy to receive it. So please could you email me? My email address is up there. Thank you so much for listening and happy writing.